Hello all from Thessaloniki. This is the second day on the third international meeting on minimal invasive extracorporeal technologies from MiECT. And I'm really happy that we made it the first day. We had already more than 250 people attended throughout the meeting and more than 5,500 views throughout the day. The topics were more about the ongoing research in this technology, and we discussed a lot about our position paper that will be focused, updated early next year. So the good thing was that we had a very nice interaction with the industry, and it seems that the synergy we have developed really produced some results. For this day, we have two main sessions. One is an overview of clinical practice from the key opinion leaders that are participating, and then we will have an update on our multi-center trial. I hope that will be a fruitful second day, and I wish you all to be participating with the same passion we are demonstrating to these meetings. So first session is MiECT in clinical practice, both rating by Professor Andonitzis and Professor Beaufreton from Angers. Polychronis.
Good morning, and nice to meet you again. So we have a session on minimally invasive extracorporeal circulation in clinical practice. I would like to welcome Professor Beaufreton. Bonjour.
Bonjour.
Yes,
hello,
everybody.
Yes. Good morning.
Very glad to meet you again for this very interesting session, and I hope it will be, I'm sure it will be fruitful. I guess that we can start right now, and there is a modification to the program, and we'll start for the first communication with Professor Erdoes from Bern in Switzerland, and have just a small discussion after his own presentation, and then the rest of the different presentation will be discussed and stand at the end of the conference. So it's my pleasure to introduce Professor Erdoes from Switzerland about the collaboration with MiECT Society.
Good morning to everyone. Can you hear me?
Yes, good.
Okay.
Let's go ahead.
Okay, so this is my presentation. Thank you very much for the invitation. I'm very happy to be here and to refer about the collaboration with MiECT. My name is Gabriel Erdoes from the University of Bern, Switzerland. I would like to provide you a short overview about the possible connections between MiECT and MiECT, which is the European Association of Cardiothoracic Anesthesiology. As you see here, MiECT and MiECT are already connected with each other directly, but also indirectly through various other professional societies. This is due to the fact that the clinical and scientific areas of interest are closely related. MiECT has been called MiECT-IC for a few months, and now represents not only cardiac, thoracic, and vascular anesthesiology, but also the associated intensive care medicine. MiECT has the claim to be the leading European association for professionals working in cardiothoracic and vascular anesthesia, intensive care, and perioperative medicine. In this sense, MiECT would like to be a leader for scientific research and education. It would like to encourage specialization in cardiac, thoracic, and vascular anesthesia and intensive care medicine. Also, MiECT strives, among other goals, to closely cooperate with other societies in matters affecting the aims of the association and its members. In the field of education, MiECT has put together a European fellowship program, the structure of which has recently been published. Basically, the fellowship program includes a basic program here and an advanced program part, each lasting for 1 year. The basic part includes mandatory modules. These are intended to guarantee a solid basic training. In the advanced part, the fellows can take modules according to their interests and obtain a different degree. Possible degrees at the end of the fellowship are these here, so cardiothoracic and vascular anesthesia, cardiothoracic anesthesia, cardiac anesthesia, cardiac and vascular anesthesia, or thoracic and vascular anesthesia. There are overlaps with MiECTs in each module. For example, EACTA has an extracorporeal perfusion management module, which intends to teach relevant knowledge in extracorporeal perfusion techniques, also including different types of extracorporeal circuits, cardioplegic solutions, and management of complications. This has been written in the first position paper for this fellowship program, and in the next one, which is under construction, we will include the term MiECT as well. I am very honored to be elected to the board of directors for the next 2 years. So I'm the new Secretary General in EACTA-IC. And just to present the structure of EACTA-IC, I would like to show you that we have different subcommittees. One of those is the cardiopulmonary bypass committee with the aim to develop guidelines and promote education. I think closer cooperation between EACTA and MiECTs would be very useful. Possible perspective could include the following points. I think a collaboration in drafting guidelines and recommendation would be nice. Involvement of EACTA members in MiECT members in EACTA subcommittees and vice versa. So MiECT members could be involved in the cardiopulmonary bypass subcommittee, in hemostasis subcommittee, or even in the pediatric subcommittee. We could organize together different webinars and congresses. We can work together in presence of cardiac anesthesia related activities, congresses, journals for a better visibility of EACTA and also MiECTs. And we can work together in funding of research grants, travel grants, or visiting professorships. Thank you very much for your interest.
Thank you, Dr. Adres, for this very interesting presentation that we will discuss right now. Before giving the talk to the audience, I'd like to ask you a question. In this training program that you shown us, is there any place for a simulation training for the young residents in this program?
Yes, of course. The program has been designed for residents, and in my clinic we have each year 2 residents who are making this program. So the next generation of cardiac anesthesiologists, and they should be trained in all of these points. So extracorporeal perfusion techniques, cardioplegia, and so on. So this is a extra place for it. Yeah,
that's a good news, because you see, as a surgeon, we have some training program for simulation, but I think it's even more appropriate for a CPV training than for surgery. So this is very interesting to see that you included already simulation program in anesthesia, in cardiothoracic anesthesia teaching. Is there any question from the audience on the web?
Yes, thank you, Christophe. I would like to ask Mark Bennett, who is a consultant anesthesiologist in Swansea NHS Hospital, just to give us his view on how we can have a closer relationship and proper training between the minimal invasive cardiac, between MiECTs, the society, and the cardiac anesthesiologist in order to promote this technology. I heard with great interest that there is a subcommittee in EACTA, I see, on cardiopulmonary bypass. I believe it's very, very important to, let's say, liaise with them and provide them input for minimally invasive extracorporeal circulation.
Yes, Polychronos, I completely agree. And Gabor, many congratulations to you and your fellow authors for the paper and the initiative and the collaboration. It's very impressive. It goes a long way towards addressing a need in the anesthetic departments to understand fully what is going on during bypass. And I think the key point is that outcomes after bypass are often seen by anaesthetists, anesthesiologists as inevitable and something they have to deal with later. Whereas the evidence presented yesterday, and which we are looking forward to being published next year in the position paper, a real tour de force yesterday, demonstrates the impact of bypass, firstly, but also how different forms of bypass can significantly affect outcomes. And I think this is the message that needs to come across to anesthesiologists, is not the inevitability of these complications, but the potential changes that can be brought about. Deb Schwinn, who I worked with in Duke in North Carolina, referred to cardiac theatre as the last remaining human physiology lab. And I think if we appreciate the huge opportunity that we have as anesthesiologists to engage in that human physiology lab as it occurs every day in front of our noses, we will make strides together between industry, between perfusion, between the surgeons and anesthesiologists for the benefit of our patients. So congratulations and thank you very much for your comment today.
Thank you very much.
Professor Anastasiadis has a comment.
Gabor, thank you for your valuable input. Now I think you're bridging two societies, MiECT and EACTA. And this is very good for us because, as you know, I have presented yesterday that the percentage of anesthesiologists in our society is roughly 10%. This is quite low for me because we advocate, as you know, in our society that this is a strategy and it needs to have a multidisciplinary effort. So what you have presented, that you are about to introduce the terms in your papers, is very, very nice because even for the anesthesiologist to start identifying which is this technology and why this technology has emerged and what's the difference, for me is enough to start thinking of something new that is here and we need to embrace it. In any way, it's absolute true that we need the original input from our anesthesiologists to optimize results. Otherwise, when you operate on MiECT and your anesthesiologist is not involving, I believe we can all create even a disaster if he doesn't comply with all the prerequisites, as we said. So it's very, very nice to hear that you're about to start introducing MiECT in your society. And don't forget that all the guidelines, especially the PBM, have highlighted the superiority of MiECT in patient blood management. That is one of your core topics in anesthesiology society. So well done, and I hope our cooperation will give results soon towards this direction.
Yes, thank you very much. So in the next paper, we will include the term MiECT because this is a different technology, and we already teach this technology in Bern, and I see that there is a teaching needed because there are many differences to the conventional bypass technique. So it is relevant for us, and it is relevant for all cardiac anesthesiologists.
Yeah. Okay, thank you, Gabor. I would like to thank you for your very nice presentation and comments, and you have stimulated the discussion, and I think that you opened the way for closer collaboration with the ACTA. And then we will move to Philippe de Sommer, and we will discuss about building a MiECT Academia. Philippe de Sommer is the president of the EBCP, and these days the BELSECT Congress is being in place, and he's there. I would like to stress that we have 25 representatives from BELSECT, so it's very important for us to liaise with the Belgian anesthesiologist, and Philippe de Sommer, as a proponent of perfusion physiology, would like to comment on the way that we can promote training in MiECT. So Philippe, thank you very much for coming to our meeting, and you can continue.
First of all, I would like to thank all of you for the kind invitation. It's always a real pleasure to come to these meetings because I think it's putting us forward in better understanding physiology. I was asked to talk about MiECT Academy. I have to be careful. I am the chair of the EBCP, but of course I will present now a presentation which is my own perspective, but we are along the EBCP discussing how we are going to change the curriculum in the next months and years to come. So this will certainly be a subject also over there. So if we want to have a MiECT Academy, then I believe it's important that we would work around the guidelines we produce together with the EACTS and EACTA IC. And what was stated in those guidelines with respect to training? Well, first of all, that it is recommended, and I think that's a very important recommendation, that there is a complete and formal period of training in an approved educational training center. And for the moment, we have about 20 of these centers all over Europe, although I have to admit that some of them are part of universities, others are still embedded in a national society, so there is some inhomogeneity between those training centers. What also is very important in the guidelines is that we need certification. And I believe that perfusionists who are actually specializing in MiECT, that they probably should have maybe an additional certification to prove that they have the necessary skills in order to do this procedure. And then it was already mentioned by the previous speaker, but I personally also believe very much that we should do more simulation, and especially in the preparation to young perfusionists into the field of MiECT. So these were all very important recommendations in combination, of course, with the fact that there should be a good verbal communication, for example. And that's another very important point, because although communication is important for every cardiac case, I believe it's even more important if we look to MiECT. Now, in the same guidelines, there is also some warning. And the warning was related to safety, and it was stated, should MiECT increase or reduce safety of perfusion? Well, probably yes, and I'm convinced also based on the new evidence which was presented yesterday that this is certainly the case. But we will have to convince people that they can do that in a safe way. It was also mentioned that it will ask for some special dedication, meaning it could be considered as a better solution, but we can also use it with a lower anticoagulation, and then we have to understand very well how to do that. But there are also differences in management. And that brings me to the next fact. If you want to prepare people, and it was mentioned yesterday, and I think it was a very important comment, that there is a learning curve. And how can we facilitate this learning curve? Well, we can certainly do that by doing simulation. And personally, I believe that the academy should be embedded in centers who can also offer this simulation. And I think Frank Merkel, who will be part of the discussion, which I unfortunately will not be able to attend due to the fact that I have to go to the BELSECT meeting after this presentation, but he did a great job with his group to show that this is a very important issue. And what you can see here is on the right side a simulation, and they look to how a perfusionist was actually interacting with all the information he was presented with. And on the left side, you can see the same in a real situation. And as you can see, it's quite comparable, meaning that simulation is really an asset that can further prevent accidents, which have not really presented in real life, but it could prevent some of the minor incidents that could happen inside the learning curve. But if we want to do that, and if we really want to embed this in dedicated education programs, we have to realize that probably we will only have a few of these academies all over Europe. And that means that we need to guarantee that also other countries which do not have such an academy embedded in their training centers, that they should be able to attract these people which were formed over there. And I think our German friends have done a great job by making this paper. And Adrian Bauer, who is also present in the meeting, was the chair of that meeting, and he actually set up the qualification, knowledge, and the task and the responsibility of a clinical perfusionist in Germany. And we as EBCP, we certainly are working together for the moment with both EACTS and MiECT IC to produce a similar publication on a European level, because this will be another very important issue to have a better training of perfusionists and to reduce further the learning curve. So to summarize, an academy should be embedded in an EBCP accredited perfusion school, because there should be, of course, also the normal physiology and technicality of a perfusionist training. I personally believe that simulation should be part of this training program. And finally, we will need training in highly experienced clinical sites, which can happen after those trainees had a simulation training, so that such a clinical site could allow faster introduction of these new trainees in their clinical practice. Thank you so much for your attention.
Thank you very much, Philip, for your very, very interesting presentation. And I believe there is much discussion on this issue. From the part of the discussants, of the commentators, I would like to invite Frank Merkle to carry on the building the MiECT Academy. And then we will pass to Adrian Bauer, because they were both mentioned in Philip de Sommer's speech. So we start with Frank Merkle.
Thank you all, and thank you for the invitation, and great job you did there, Philip. I firmly believe that simulation is part of modern training, both for conventional bypass and also for mini circuits. And as you all know, we have a simulation center in Berlin. We're using it for ECLS, we're using it for CPB, we're using it for surgeons, we're using it for perfusionists, and also for anesthesiologists. Now, we haven't used it so far for mini bypass, but we're more than ready to welcome any ideas. So now we have purchased a second simulation. We have a second simulator. We have both the Orpheus and the Califia. And the Califia, I think, is more suited for mini bypass. So together with Adrian Bauer, we have already thought about a setup where we could offer both clinical environment in Adrian's hospital, which is about 100 kilometers away, and theoretical and simulation training in the Berlin Academy. So we're now putting together a curriculum, and maybe Adrian can comment on that in a second. So our combined efforts, we would be able to do that in spring, early summer next year, and offer a pilot course, which could be open for everybody internationally, so that we can go from there. So that's my proposition.
Okay, Adrian.
Yeah, okay. Thank you very much for the possibility to talk about it. Thank you to Philip. It's good to have you as boss in the EBCP. So we have to consider even that things. We should not flatten the curve like in the pandemic. We have to make it a little bit more stepping on the curve, this learning curve, before we go on bypass. And I work with MiECT on mini bypass in that case. I work on MiECT 20 years ago. And the last 10 years, I try to get more colleagues on board. And I always have the feeling when I leave a clinic, I know they don't do it, because they don't see all the accidents and all the problems with the MiECT system. When you go directly on a patient with them, with the colleagues. If you have the possibility to doing a course beforehand and show them all the things with air, with volume, and so on, that will absolutely help that people to step in that process. And I would absolutely support also and would emphasize the MiECT to put the simulation and the training in the consensus paper, probably as certification. You have to reach a certification in MiECT, and then you can go to the patient. That could be one way to get more people on board, to get the gatekeepers, us perfusionists, we perfusionists on board. So that's my statement. Thank you very much.
Thank you, Adrian. And now I would like to invite Hans Seiler, who's the man behind simulation, to give us his point of how could he, from the part of Biomed and Califia, promote training on minimally invasive extracorporeal circulation.
Yeah, good morning, everyone. Good morning, Adrian, Frank.
Good
and
morning.
The boss, of course, Philippe. Hey. As I said yesterday, mini bypass was definitely not on the priority list for the Califia simulator in the last 1.5 years, simply due to the demand on ECMO. But I spoke to Philippe last week and to Frank as well. So we really want to integrate mini bypass as much as we can. However, we need your input. We need to know what you want and what to do. We need really helpful input in terms of a curriculum to set up a real beneficial simulation program, not only a toy, not only a Mickey Mouse game. So, and if I would be allowed to use this slogan, I cannot for legal reasons, I would use a slogan from Nike: nothing is impossible, just do it.
Yeah, we are on a good way in Berlin to have that curriculum. So let's meet up there and go ahead with it.
Adrian, anytime you want, we can work together, and you know, the integration into algorithms, it's not a problem anymore. So it's just a question of a few days, and then it's implemented.
Great.
Thank you, Hans. And now I would like to invite Professor Anastasiadis for a short comment.
Thank you, Polychronis. Just a comment that I will use as an evidence from a senior perfusionist that you all know, James Ferguson, when we had the meeting in Thessaloniki, no, in Athens, 2016. He presented his own views on this training in his school in Phoenix, Arizona. What he said then is that when the perfusionists started from the beginning, the school, the mini systems, they didn't find any difficulty or any complexity in this. So what you senior perfusionists find it as a demanding procedure from the youngsters that start from the beginning being trained in this technology was the standard practice. So for them, it was obvious there was no issue because they didn't know another way. So with this group of perfusionists, he proved that there is absolutely no difference when your training is this way or the other way. And I believe what you are saying is very crucial because at least the young perfusionists that coming into the profession should know from the beginning the mini bypass, because that will give them, you know, the background for adopting this technology throughout their practice. This is my comment.
But I believe it's also important to stress on the fact that there are some minor physiological changes. For example, even if they cannot achieve what they normally would consider a normal flow, this is compensated for example, by a higher hemoglobin. And that's important that they understand that. So for that reason, I believe it should be a close collaboration between a good, firm theoretical background with simulation and clinical practice.
Okay, thank you. And I think that with Professor Beaufreton, we can move on. Professor Beaufreton.
Yes, just a comment about what I said. In my center, you know, all the perfusionists are going to be trained for MiECT, and they do not receive conventional training formation finally. And another point is that it is very important to consider perfusionist training and anesthesiologist training, but also the surgeon training. And for several practice, for instance, like reduced anticoagulation, if the surgeon is not trained for that, it would be a problem. So let's consider that you are training a group of professionals, in fact. Okay, if you do agree, we can continue. And if I follow the program, it should be to Dr. Popov from Moscow to discuss what is setting up MiECT program. Do we have Dr. Popov?
Yes, I am. Dear colleagues, first of all, I would like to thank organizing committee and personally Professor Anastasiadis for opportunity to participate in such a creative and friendly meeting. Here's my disclosures. There is a great history of perfusion in Russia. Dr. Bryukhanenko developed an experimental model of machine in 1926, and the first successful operation with fat lung machine did Professor Vishnevsky in our center in 1957. By now, the amount of CPB cases over 43,000 per year, but mortality rates still range around 3%, and these percentages includes the mortality rates with perfusion. Conventional CPB remains the primary method of organ protection, but the increase in patient comorbidity and complexity of cardiac surgery requires improved perfusion safety. Can we reduce adverse effect of perfusion? More feasible solution to change the technology and use MiECT. For the implementation of MiECT, we use various sources of information. A particularly important source is the MiECT. One of the most critical moment is understanding that MiECT is not just perfusion, but also an integrated strategy which is ensured by teamwork of surgeon, anesthesiologist, and perfusionists. One of the most critical moment, therefore, MiECT technology is now suitable for valvular and more complex operation. The goal of introduction of our MiECT program is an opportunity to safely use type 4 perfusion. To understand whether we need this technology, we need to answer a few questions. Are we satisfied with current condition? Why do we need to implement it? What are the advantages? What results do we anticipate? What the price of challenges and complications? How to avoid them? To answer the main question, we have investigated our colleagues' experience in MiECT, have participated in different workshops, conferences, have visited some hospitals where MiECT is widely used. Walter Lillehei, the man who performed first successful open heart surgery using crossover blood circulation, said the invention of any surgical technology requires going through 6 stages. Sorry, could you... So first stage, after introduction of an idea that's not work, that won't work, this has already happened. And last stage, after a big series of successful operation, you know, as I expected, this technique appears to be very effective. So introduction of a technology has 3 parts. First, understanding the necessity. Second, going through introduction issues with organized structure and going through learning curve. And finally, fix it with teamwork and structural training. We believe that structural training and teamwork is the main factor moving from simpler types of perfusion to the most difficult. The key problem in Russia includes the learning curve and the cost of MiECT circuit and necessity in additional equipment. So it's our history and setting up a MiECT program. 2008, I met this technology in a CTS meeting. 2011, we did first cases type 1. In 2013, our team had been trained in Regensburg. Since 2014, we routinely use type 1. In 2017, we trained in Hasselt and modern and real MiECT system. Since 2018, we adopted hot lung machine and air eliminating system. Since 2019, we participate in MiECT meeting. On April 2021, we had one training with Professor Anastassiadis and his team online. We took type 2 MiECT and adjusted setup is for our condition. We did not have any complication associated with the implementation of MiECT. A systematic approach helped to avoid serious mistakes and failures. What can be done next? Expanding of technology in Russia. Involved of professional society, accumulated positive experience, cooperation with MiECTs and key leaders. Current issues are routine use type 2 MiECT, integration of type 3 and 4, second stage MiECT training in Vishnevsky Center, research implementation. Thank you for your attention.
Thank you, Dr. Papa, for this communication. Is there any question in the audience? I have one, if you can answer. Who do you think could be a reference to give some certification to train new center interested in MiECT? What kind of center, under which auspice?
Question especially for me?
Yes, for other people.
Anyway. In Russia, it's a challenging problem because we don't have real perfusion setup, real perfusion training, real perfusion condition. So we can establish it in Russia. Because perfusion followed cardiac surgeon, and famous cardiac surgeon does not need don't need any changes of perfusion. It's most challenging problem in Russia. Second of them is of course cost of this type of system, and next is perfusionist not want to change his real practice and real circuit. So.
Okay, may I consider, and this question would be mainly dedicated for the heads of these MiECT International Society, to consider that this certification for training center could be accorded by our International Society for minimally extracorporeal circulation, and it makes sense to my opinion.
So I have some proposition, and I have I would like to create training center in our institution, if possible, with MiECT society. It would be great, and many guys, many surgeons, and many perfusionists in Russia needs this.
Kyriakos, do you have any opinion about that, please?
Yes, thank you. We are collaborating with Vadim lately, and it's really a great opportunity for Russia to adopt this technology because they are very knowledgeable and very willing. As you have heard, there are some burden. However, I think that can be overcome with the help of motivated people that want to help and to, let's say, be part of the team there. What I would say is there is a 4 steps training program if you want to succeed with this technology. The first step is when you approach this technology through the literature, with books, with training courses like this one, or either online or hands-on or whatever. So this is the first approach. As soon as you have this first step, that means everyone is aware of this technology. Second step is to form a team. And this is critical because if you don't have the team, despite having training, you will never succeed if you go yourself and trying to integrate this technology into an environment that might not be hostile, though it would be, non-interested in this. And you will try to convince your surgeon to comply or your anesthesiologist not to give that much fluid, don't influence that much the intravascular component of the patient and so on. So second big step is to form a team, try to build up a strategy that can fit in your institution and be able to, let's say, integrate into clinical practice what you have learned throughout the training process. Then the third big step is start doing clinical cases. Some people, like the Canadians I know, which we have also trained some time ago, in the second step, they had some experimental, some animal house training as well with the team. So they have first applied this technology to animals before going into the third step. Third step is clinical practice. And I believe, especially in an unexperienced center, it should be proctored. So the first cases should be simple CABG cases, epicardial surgery, not intravascular. Don't employ too much physiology issues there, and start doing the CABG cases first, proctor cases with the team that has trained you. What we have indicated in the literature is after 50 cases, the learning curve goes like this. So after 50 cases, the whole team really takes the maximum benefit from this technology. And then it starts the fourth step, which is to employ this technology to other cardiac case mix. What we advocate is start with simple AVRs, which is very, very easy. It needs some extra volume handling there. And because you open the heart, it's intracardial procedure, you might have any air issues, but I think with a type 3 you can overcome, though, as you know, I advocate type 4 because it's easy to any kind of unexpected scenario. But as soon as you start with the AVRs, you see it's very easy then to go on with the mitral, right heart, and then of course if you have the hybrid system, you go for aortic arch, reduce complex cases, any surgery, but this is advanced. So for me, these 4 steps need to be followed for anyone who wants to build up a MiECT program. And as Vadim pointed out, I believe that our society, and as you have heard, EBCP with these expert guys here, they're really very keen to help. And don't forget the companies. From the first beginning, the industry was very close to us, and they really, let's say, be stakeholders in this training scheme. And as Hans Seiler pointed out, I think also simulation may be added in building up a MiECT training program.
Thank you, Kyriakos. I must say that I fully agree with you with this proposition. And should we write this kind of proposition in a position paper under the auspice of our society? That's a question. But I totally agree with your 4 steps presentation. Other question or comments?
Yes, Mark Bennett would like to make a comment.
Vadim, thank you very much. In introducing this, you have to persuade the whole team, and perhaps that starts with accepting that things can be different than they are now. That requires us all to be rather more humble than we might be. One thing that matters here is what outcome measure we're looking at. And of course, you quoted mortality. But of course, there are now better measures coming in which will serve this purpose, return to home or quality of recovery. And I think my final point is that we must take advantage now of improvement in risk calculators, such as the STS risk calculator, which instead of telling us the risk of mortality is now a lot more didactic in telling us what the risk of a long length of stay, of infectious complications, and of AKI. And if we concentrate on these percentages, we will become more humble and we will accept that things can be done better. So thank you very much for your presentation.
Yes, I agree with you. I totally agree. And one question is, Russia is a very great market for technology. Very great market. If the guys believe in MiECT, it would be great. Would be great, and for patients too.
Okay, let's move on with this meeting. And it's time to ask Professor Shapira from Jerusalem to present his presentation.
Christoph, Professor Shapira is not online, so we will proceed with Cyril Serik.
Okay, good. Okay, go ahead with Sir Serik on the blood conservation and the perfusionist perspective.
Hey, good morning. So I'm just going to talk about blood conservation and my perspective as a perfusionist. I think we all know there are many studies out there that show that there's an advantage to MiECT versus conventional cardiopulmonary bypass. But I think most comparisons use conventional cardiopulmonary bypass that has not been optimized. You see higher prime volumes. Some places, some centers, and randomized controlled trials and the reviews have priming volumes well over 2 liters. But normally we see around 1,500 non-coated circuits with large surface areas. People are using roller pumps and blood conservation methods like autologous priming and cell saver aren't in use in comparison. So I think as a perfusionist, you rationalize the necessity of MiECT by saying that all you need to do is optimize conventional. So, and you rationalize to yourself that this will give you the same benefits without the technical difficulties that may arise or be associated with MiECT. And some of that was discussed yesterday by Cardiothoracic. So air handling, volume issues, etc. We all know that, and we all suggest that prerequisites to MiECT should be sequestration of suction blood, retrograde priming, using the coated circuits, centrifugal pumps, and emergency training techniques, etc. But a lot of things, but basically, but nobody does a comparison of optimized conventional bypass. So, before we went into mini bypass MiECT systems, we did optimize at Toronto General here at our institution. We did optimize our circuits. So we reduced our prime. We had reduced priming volume. We shortened tubing lengths and used balance coated tubing from Medtronic. I used a centrifugal pump, integrated arterial filter with the oxygenator, with coated Cortiva oxygenator. Cell salvage was used before and after cardiopulmonary bypass, and we basically wrapped every procedure. And then we looked at MiECT, and basically we decided to go with a Type 3 system. Many of the same components of our optimized system, Medtronic Affinity centrifugal pump, the fusion oxygenator. We introduced a Capiox bubble trap from Terumo, used a hard shell reservoir to send vent blood to. Cardiotomy suction was available, but only used in emergency. And we use cell salvage throughout cardiopulmonary bypass. So if you look at our systems that we use, this was the on the left is our optimized system, conventional system, and on the right is our MiECT system. So they look, again, looking same components, but different configuration. And this is just a comparison of both. MiECT system, there's no venous reservoir. The arterial pump, we use a totally Corteva coated circuit versus Balance. They are, however, both are coated. Oxygenator is the same. Cell saver use in the MiECT system was during the whole procedure, whereas just pre and post-op in the optimized circuit. Obviously, no bubble trap in the optimized circuit compared to MiECT. Wrapped suction blood was processed in the cell saver for MiECT. Our static priming volumes were basically the same. We held 930 mils. Dynamic priming volume for the open system was about 400 mils higher. ACT targets are the same, etc. So we did a preliminary study comparing both. It was basically a retrospective analysis where we compared 61 MiECT cases to 51 optimized conventional cases. And this is first when we started doing MiECT. So this is from 2000, starting in 2009. All were done on CABG cases performed by the same surgeon, and we analyzed platelet function, ROTEMs, and looked at blood transfusion requirements. So what are the results? Now remember, this was our optimized circuit. This was well established at this institution, and MiECT was new technology and technique at our center. So preoperatively, patients were the same in both groups, except that MiECT, for some reason, maybe subconsciously, I guess, they were smaller, significantly smaller patients, statistically smaller, clinically not sure, but they were statistically smaller patients. But everything else was, incidence of everything else was pretty much the same. Pump times and cross-clamp times were pretty much exactly the same in both groups. And if you look at the effects of hemodilution, prime volume was still smaller in the significantly smaller in the MiECT group. 380 versus 535. Wrap volume was significantly higher in the MiECT group, and I think this was more due to the fact that we wrapped venous line a lot more in the MiECT group than we did in the optimized group, and our total fluid balance was not quite significant, but it was lower in the MiECT group. And if you look at the percent hemoglobin drop, and this is basically on initiation, significantly lower, and at the end of bypass was 15% versus 20%, 50% in the MiECT group, which is 20% in the optimized group. Cell saving, what we processed with the cell saver, obviously because we used it during the whole case for MiECT, was significantly higher, 400 versus 350. Sorry, and red blood cells given back to the patient, about 500 red blood cells versus 150 for all patients. And this is just a depiction of the. You can see that our volumes are a lot tighter, and the MiECT group. We looked at platelet count and function. So there was no significant difference at the beginning. We did take samples. Our platelet function was taken just before coming off bypass when we were at 36 degrees, when the cross clamp was off. Basically, our total platelet function was significantly higher, 86 versus 76 in the optimized group. And again, this is just looking at how more increased the platelet counts and platelet function are. We did look at ROTEM. We did not find any significant differences. And then looking at blood product use, 45% of our optimized, even though we did optimize, 45% of our optimized patients received blood transfusion versus 38%. So still a bit high, but no significant difference. But a trend, we did like to see that trend towards lower. So our now, and this has to do with we are looking at, this is a learning curve for MiECT was included in this. These patients did have a smaller BSA, and it was significant, so that might contribute to this as well. And again, remember, optimized cardiopulmonary bypass. So our conclusions, definitely MiECT leads to less hemodilution despite optimizing cardiopulmonary bypass, and despite no differences in blood transfusion, there was significantly less platelet activation compared to optimized cardiopulmonary bypass. So, from this, we can easily say, yeah, even when you look at conventional and you try to optimize cardiopulmonary bypass, MiECT is still better. And I do think that obviously we need more randomized controlled trials for MiECT versus optimized conventional. And I think we'll be able to see that with the subgroup of in the COMEX trial. And one thing we didn't do was we didn't compare baseline to postoperative platelet function and thromboelastography. And I think that's something that we will do in the future. And again, there won't be that learning curve involved, so we'll truly be able to compare MiECT, from an experienced center to optimized conventional experience center. Thank you very much. I'll take any questions.
Thank you very much, Cyril. First of all, thank you very, very much for taking part in the Congress Live, because we know that it's very, very late in Canada. So thank you very much for live participation. And I would like, let's say, cordially to thank you because you provided an evidence that was, let's say, missing in the whole part. So you provided the difference between the best optimized extracorporeal circulation and minimally invasive extracorporeal circulation, and you have shown that there is a step forward even for the best optimized circuit. There is still a road, there is still a space for improvement with minimally invasive extracorporeal circulation. And you have given the fields that improvement is seen. And as we constantly have shown that the platelet function is very, very important. So platelet function is not deranged with minimally invasive extracorporeal circulation. And this will create clinical importance, but you need large number of patients, you need special indicators to point this out. There may be in the first phases a subclinical improvement, but then it is definitely better. So I would like to ask first Professor Anastasiadis for a short comment.
Cyril, thank you for your commitment being 3 o'clock in the morning with us from Canada, and this is significant. So the president has highlighted something that is, as Polychronis said, a result that we were waiting from people like Cyril, being experts in these optimized circuits that are not common. I mean, when we say conventional CPB, we don't mean this design that has been exposed to us by Cyril. Though, with these circuits, what we have seen is eliminating the open reservoir and having a closed circuit. You see that there is still a big difference in coagulation. And I would say this is with not a low anticoagulation protocol, and it applies just for CABG cases. So if you include these two parameters into your study, I mean, reducing the ACT and the protamine at the end, and also applying that to complex cases, I believe then you will find a huge difference, and that makes, to me, the big breakthrough to this technology when we say cardiac surgery. And last but not least, hematocrit drop was significant, but we shouldn't forget all guidelines, as highlighted yesterday, both joint European and the American guidelines has as a PBM, patient blood management, level of evidence 2A, class 2A level of evidence B, that MiECT is the ultimate tool if you want to have PBM to your patient. So thank you, Cyril, and I believe this has to be published from your side, so as we will have it as a reference.
Yeah, no, we're definitely in the process of publishing this. I think, and this is the, to me, this is the big point is, we've optimized, despite optimizing conventional bypass, and I think you hit the nail on the head. Don't see many of these studies. The studies out there are looking at, things that we've done basically 10 years ago. And, where didn't look at, we were using roller pumps, higher prime volumes, and, et cetera. So I think, optimizing bypass, which is exactly what, from Rob Baker's comment yesterday, looking at, I think most perfusionists look at, mini bypass and say, well, I can optimize bypass and get the exact same results. Well, if you optimize bypass, you will get better results, but you won't get the same results, right? MiECT delivers a lot better results more than optimize. Optimizing bypass is, the way to MiECT. I mean, I honestly don't think you should even try MiECT without optimizing your whole circuit first. So, and I say that to people who really want to do MiECT. I say, optimize your circuit, and then once you do that, then look at the results and go to mini bypass, because it's a natural progression. I think, yeah, I do think that's very important.
Thank you, Cyril. Dr. Elezawi would like to make a comment.
Yeah, hello. A very interesting study. But let's not forget that the main drive for optimizing a conventional system is MiECT. So that was the main driving force to that. So I have two questions. First of all, why do you think you were more aggressive in wrapping the MiECT systems? Is that a technical issue? And second, how do you decide on platelet transfusion? Because I was a bit surprised that would be, I think it is a bit, the incidence is a bit high, the rate is a bit high. And I was surprised that it was more in the MiECT system. So what is how do you take the decision for a platelet transfusion?
I'll just answer the platelet first. I think platelets, if basically if our functional platelets fall below 50,000 units, will transfuse. We did have a lot smaller patients in the MiECT group. So, we had in the conventional group, I think our smallest patient was about 70 kilos. And I think in MiECT group, we had patients at over around 45 to 55 kilo range. So that was the smallest patients, not all patients, but the smallest patients. And those patients were the ones that actually got the transfusion. As far as the more aggressive wrapping, I do believe I do believe there probably is a bias there. To be honest with you, I think you're due for the optimized circuit. We did wrap every case. I think venous line was not wrapped as often, and if you look at the venous line, it's about 200 cc. So we did look at I think we wrapped the venous line more, and I just felt that on the other side of it, it was just seemed easier to wrap. So technically, it just seemed easier to wrap patients on MiECT than it was on the conventional. Someone else have a comment?
Is there any other comment?
From Dr. Diaziano?
Yes, can you hear me?
Yes,
Yes,
good.
yes, Marco, please.
I'd like to congratulate with Dr. Serik for showing the superiority of MiECT versus optimized CPB, and I'd like to, going around the penetration, the less than expected penetration of MiECT in our practice, I'd like to emphasize how nowadays we should consider important measure of outcomes like hemodilution, like coagulation function, because I think wrong expectations generate disappointment, and disappointment is at the base of low, let's say, uptake of this technology. So if the expectation is to decrease mortality or to decrease stroke rate, I think with MiECT, I think we generate disappointment and then laziness in the professionals. But nowadays, I think in 2021, the hospital mortality rate and stroke rate for AVR or CABG is extremely low. It's approaching 0%. So I think under this condition, coagulation, hemodilution, blood transfusion get importance. So I think it's important we emphasize that we set these new measure of outcomes as new hard clinical endpoints in our practice. I don't know what you think about this.
Yeah, no, absolutely. I think I think anything that we measure. I mean, the proof is in the pudding, as we say here, I guess. It's if you look at clinical outcomes, I think the soft points make a big difference. Like platelet. I mean, platelet function, blood transfusions, and even though we did see a decrease in blood transfusions, We didn't, in this cohort, we didn't actually see a significant difference in blood transfusions. But I think it's very, you have to look at, everybody has to look at their own outcomes, I think, to adopt something like this. And, some people might look at these results and say, well, you know what, there's not a big difference, so why don't you just go back to optimize, right? But again, there's a learning curve here that we have to put into, or that we have to take into account. And and we felt with these results, our surgeon said, yeah, I mean, my patients are drier. They're still, they're doing a lot better. The results that we see don't necessarily results that we have now. I think our patients are doing better now. So if we take our cohort of, if we do the same analysis now, I think we would see a lot better results. But to see those results for us was still very very intriguing, and kept us, yes, we're on the right track, right? So the thing is, once you go into this and you be a believer, and you see the benefit to patients, you're not gonna start randomizing or flipping back between MiECT and conventional. And I think what's nice going forward is, we are part of the COMEX trial, so we will be able to take a look at an actual randomized subset of patients. Once the COMEX trial is over, we'll be able to look at optimized circuits as well versus MiECT, and see if there's a big difference. So I think there's a lot more to come on this, and I think it's very exciting.
Yes, thank you, sir. What Marco said is very, very important. I mean, consider that the studies are, let's say, exclusively being done by very, very expert centers. So if Toronto General Hospital is having a difference by using MiECT instead of optimized extracorporeal circulation, this very, very experienced center, even if you do not find a reduction in the rate of blood transfusion, which will be evident if you have larger series of patients, and if Marco, who is really a pioneer in ultra-fast track cardiac recovery, then this will mean that there will be a greater benefit for the whole cardiothoracic community, because let's say the standard cardiothoracic practice is not what is being done in Toronto General Hospital, or what Marco Diosanio is producing with an AVR, let's say, mortality rate or complications rate approaching 0, but it's a lot higher, as we see from the large registries. Even the STS registry provide data that there is significant morbidity and mortality still in cardiac surgery. And if we would like to compete with the cardiology in terms of transcatheter therapies, especially in elderly population, then we need to offer this outcome will become significant. So please, Professor Beaufreton, you can continue.
Thank you, Marie-Chris. Let's continue with the presentation of Dr. Starinieri, if he's available, about modular minimally extracorporeal circulation.
Okay.
I don't know if we have some. Yes.
I will present. Yes, it's my turn to present. Okay, I will present about the modular MiECT.
Okay, good.
Okay. So we will carry on. So I will try to expand, sir. I will keep the same way of thinking about modular MiECT, which, in our view, and as MiECT is voted yesterday, represents the state of the art in perfusion. We were all discussing what Rob said yesterday. So Rob is a clear proponent that there is a need to develop criteria for reporting in order to better understand what we are doing. Ashraf pointed out that we need to report clearly how we use, let's say, the shed blood. So we see that the conventional cardiopulmonary bypass is not still what was what was meant years ago. Autotransfusion is used by 30 or more % of patients, but there is still scope, there's still space for improvement. There's high percentage of roller pump use instead of centrifugal, and also biocompatibility is an issue. They all advocate tip-to-tip biocompatible surfaces, but we can see that this is very, very low in registries, and cannula most of the time is not heparinized, and you can see that all centers use an open reservoir in the registry of Australia, New Zealand. So there is space for improvement, and we need to clearly report and define the components of each system in order to make better comparisons. So, as Cyril pointed out, perfusion community desired to improve cardiopulmonary bypass. So they have actually provided certain components, including coated tubing, integration of a centrifugal pump, self-salvaging, and keeping the line short in order to provide an optimized extracorporeal circulation. And they had the very, very good results that Cyril made in Toronto General Hospital. But minimally invasive extracorporeal circulation integrates elimination of cardiotomy suction plus a closed system. And this is very, very important for optimizing not only better, but for clearly turning extracorporeal circulation to a physiologic circuit that is fully biocompatible for the patient, and it's fully compatible to the body's physiology. And we had the discussion yesterday with Ashraf and Adrian Bauer on the role of shed blood recirculation to the circuit. So having a closed system is very, very important in terms of avoiding shed blood entry, which includes a lot of inflammatory factors into the circulation. So integration of a closed system in an optimized extracorporeal circulation circuit is of paramount importance for reducing the inflammatory response and for keeping body's physiology. And the more patients that you get, and the more fanatic, the more dedicated you are with this technology, then you will produce better results. And the more countries and the more institutions use this technology, this will have a global impact to the industry and to the patients. This is very, very important. I have nothing to add on optimized extracorporeal circulation circuits because Cyril covered the whole issue completely. So they have optimized certain components, but they have reached the minimal invasive extracorporeal circulation by doing a closed circuit, and they have seen even better results than they had with the previous circuit. And I would like to comment that perfusionist is a scientist, and perfusion outcomes, they are very, very important outcomes. So I totally agree with Marco, but that we need to get out of the trialist thinking of producing results that have difference in mortality in order to consider one procedure better than the other. If we are focusing on perfusion, there are perfusion outcomes that are very, very important in defining the technology. And modular MiECT gives an answer because it eliminates any safety concern regarding transformation of optimized extracorporeal circulation to a totally physiologic circuit. So the circuit that Apostolos has designed and Apostolos Deliopoulos is using represents a closed circuit with coated tubing, centrifugal pump, membrane oxygenator, integrated venous air removing device, a soft bag reservoir for facilitating volume management, and a standing by component with a venous reservoir that facilitates immediate conversion to an open circuit in case of an unexpected scenario. And Adrian Bauer pointed out from the first MiECT symposium that we in Thessaloniki, we were very, very keen in developing all advancement in perfusion technology in one single circuit, and this is minimally invasive extracorporeal circulation. The features of the system have been discussed extensively, so this is the complexity that Professor Anastasiadis has shown yesterday of the HEPA circuit, so it's minimization, but together with a kind of complexity that would actually prevent any unexpected scenario from happening. And what has been pointed out clearly yesterday is that for 95% of procedures is a closed type 3 circuit, and for only unexpected scenarios, it can be transferred, it can be converted into an open circuit by incorporating the standing by component. And this is the circuit that we were using a few days ago, and it has been replaced by the quantum heart-lung machine. And also, I would like to stress the necessity of implementing a cell-saver device into the system in order to process the shed blood and avoid inflammatory factors getting into the patient. The modern transfusion devices clear in 99% of the inflammatory mediators that there are in the shed blood. Air handling and volume management are very, very important in modular minimally invasive extracorporeal circulation. Apostolos Deliopoulos has integrated some simple but very, very sophisticated bubble traps and baby bubble traps in order to facilitate air handling. And that's why training is very, very important, because it will create confidence to the perfusionist that he could do it and prevent any unexpected scenario. But even at this setting, if air massively enters into the system, then the circuit can be immediately converted into an open circuit, as seen in the video. And this is for the limited time period that is required for the surgeon and the operating team to correct the defect, and then the circuit can close again. Volume management is facilitated with the soft bag. We've discussed about this extensively. And with this type of circuit, as we have shown in the publication that was published this year, it's 100% technical feasibility without any issues. Professor Anastasiadis pointed out yesterday that the conversion rate that we have encountered in a series of 403 patients was 4.5%, the true conversion rate, excluding thoracic aortic dissection and heart surgery that definitely requires an open circuit during the time of circulatory arrest. So for 95% of the procedures, you can do it with a closed circuit, and not for all of the time. The conversion to an open circuit was required for 40% of the operative time as a mean. And I believe that the more experience you get, the lower the time that you will need for a conversion to open. What's the main cause of converting to an open circuit? Is air entrainment into the circuit. And Ashraf, actually, his landmark paper that he had produced advocates the type of, the smart type, the quick connectors for the accessory component, so that it could easily be converted, the circuit from a closed to an open one, and otherwise you're not obliged to use the component. And also Andreas Liebold stressed that building a modular MiECT program facilitated in doing valve cases and proceeding with minimally invasive in almost every cardiac case. The systematic review showed that on a quantitative synthesis of results, less than 2% of cases would need an open circuit. We say that, okay, almost 5% can use a modular design that overcomes any safety concern and creates a safety net for the perfusionist to enable surgery in all case mix. So every statement that was mentioned by Professor Anastasiadis yesterday on safety regarding air handling, regarding volume management, regarding reduced circulatory flow is erased. There is no concern with a modular MiECT circuit. You can perform every case in all cardiac case mix. And Dr. Vadim Popov is setting up a program in Russia with minimally invasive extracorporeal circulation. So as long as there is proper training and the team is ready, instead of proceeding with type 2 and type 3 and type 4, with progressively advancing procedures from coronary cases, passing the learning curve from 50 cases to AVR, then moving to mitral cases, sorry, I missed it, then you can use the modular configuration in order to start with it. Start the CABG cases first for the team to get acquainted to the system, and then proceed with AVR and mitral valve replacement. So if the team is dedicated and is there, and they have the proper training that MiECT ensures, and the industry is committed in promoting, and simulation training is also here. And as seen in this Congress, there is collaboration between clinicians. I mean, we have quite a large network. We mentioned yesterday that MiECT extends to 47 countries. So we can really promote training, and we can really advance the modular circuits that could produce the result that Cyril mentioned earlier. And I'm pointing out again that if Cyril in Toronto General is having this positive outcome with minimally invasive, with minimally invasive extracorporeal circulation, which resembles the Swiss knife and represents the state-of-the-art perfusion technique, then the whole cardiac surgical community could produce even better results, because they will definitely see difference in end organ protection by reducing inflammatory markers, in postoperative incidence of atrial fibrillation, in having the patients more physiologically. And this will create a financial benefit, because by reducing blood product transfusion that is liberal in most of the countries, then they will see the financial benefit as well. So I would like to thank you, and the whole issue is open for discussion.
Thank you, Chris, for this very interesting and fascinating presentation. Do we have some comment in the audience?
Yes, I have a question. Good morning, everyone.
Hello, Ignacio.
Hi, good morning. Thank you, Professor, for this opportunity and a very, very nice, very good presentation. I have a question for you. What do you think about the tips and tricks of the perfusionist, for example, in the volume management? In my experience, I see that many perfusionists have different approach, for example, for use of a vasodilatation or use of soft shell venous reservoir. Do you think that this approach have a different clinical impact in modular minimally invasive extracorporeal circulation?
Thank you, Ignacio, but I will address this question to Apostolos Deliopoulos, who is here to give us his overview of volume management in modular MiECT. Thank you. Thank you, Apostolos.
So in our modular system, we have a soft bag in order to manage the blood volume. And if the patient is overloaded, we can get volume from the patient to this bag. And if there is need of volume, we can get it back. That is the technique that we handle the volume management.
Okay. And when you prefer use a vasodilatation and when you prefer open the bag?
I don't use vasodilations.
Okay.
Okay. I go only for goal-directed perfusion.
Okay.
And if I have high negative pressure, this is an indicator that the patient needs volume.
Okay, thank you so much.
You're welcome.
Thank you, Ignacio.
Can I make a comment?
Yes, of course, Marco. But first, I would like to ask Serdar Gunayudin to make a comment, and then you will comment. Thank you.
Thank you very much. So I would like to ask Marco indeed for the next step of using modular systems in minimally invasive cardiac surgery. Do you have any difficulty in venous drainage? Because, you know, in minimally invasive surgery, we already have some problems with venous drainage. And if we use MiECT plus minimally invasive surgery, do you feel any extra problem in venous drainage?
The question was to me?
Yes, yes.
Yeah, thank you. So, yes, MiECT actually is a part of our an approach that we call 360-degree approach, where surgeons are doing minimally invasive incision, perfusionists are using MiECT, and anesthesiologists are using ultra-fast track anesthetic protocols to fasten patients' recovery and increase patient satisfaction, let's say. And basically, we're using MiECT in the aortic valve population. but I'm planning to start also for the mini thoracotomies. We started just yesterday using the Nido cardioplegia for the mini mitrals. So we were using custodiol before, so it didn't take, it didn't make a lot of sense using MiECT with 2 liters of, let's say, custodiol cardioplegias. But now that we're using Del Nido, probably we making an extra step forward for the mitral patient. So in the aortic valve population, MiECT was okay. Was okay. We use.
We've lost the connection.
I lost the connection. So until
Yeah,
we
maybe
have...
I can also ask a question or make a comment if I'm allowed.
Okay, Frank.
Yeah, because Ignacio just said something very important, I think, and that is because now we have more or less standardized circuits or different types. We have the advantage clearly laid out using mini systems, and the question he really had is, what about all the other perioperative factors? So we have the surgeon, we have the perfusionist, we have the anesthesiologist. And I think some of those routines or standards have not been established and verified scientifically enough. Just the question you raised, Ignacio, like, how do you actually take volume out of the system? Would you use a vasodilation? Would you use a bag or other aspects of this sort of adjunct measurements? Have not been discussed in full. So I think this is another way to go and to set up a guideline or clear comments that it is necessary.
Yes, thank you, Frank.
Any other comment?
Well, I think Ashraf has categorized the type 4 MiECTs, and I believe he should mention the types that needs to be well known when we say modular MiECT system. So, Ashraf?
The point is that MiECT can, type 4 systems or modular systems, in my point of view, can be subdivided into two groups. There is this system which is advocated in Thessaloniki, which is a hybrid system, which has a clear advantage in training because you feel safe, you open a clamp, and we have just seen in the film how you can go from a closed circuit to an open circuit in a matter of seconds. There is another philosophy of having what I would call a plug-in or plug-and-play system, where you have your accessories that you can integrate through quick connectors, which are an integral part of your venous and arterial lines. And in that, it has the advantage that you reduce costs because you don't use these accessories all the time. If you don't need them, why integrate them into the system? It's like the spare wheel in your car. You don't have it integrated as a redundant safety equipment, and it has the charm that you wouldn't ask when you ask me about a plug and play system, you would not ask me how often or how much of the time I'm an open circuit or in a closed circuit. You wouldn't ask me if I use cardiotomy suction, because if I don't integrate a cardiotomy suction, then obviously I'm only using cell saver. If I haven't integrated the reservoir, I can tell you straightforward that the incidence with a success rate in that study that I presented, or in the RockSafe study from 2010, where we had these 250 patients in each group and included CABG and AVR, we introduced a reservoir in one single patient. And cardiotomy suction, I think it was in 10 patients. So technically, we were in a closed system for 251 patients, and only a single patient needed a reservoir, which makes it quite easy to publish your results, because it's obvious from the start how many patients needed an open system. But that's just a remark.
Professor Anastasiadis would like to comment.
Just a quick comment to Ashraf's very nice way of subdividing type 4 MiECT systems. What we advocate, though, is you can complex both the cell saver and the system. So what we are doing is we're utilizing this hard shell that is standby component as the reservoir for the cell saver. So we collect the shed blood there, and we all the time we utilize it. So it's not something that is not useful for us, because we save money from the cell saver circuit, because we utilize this hard shell reservoir. So how we use it is in cases that we have a lot of blood into this hard shell, more than 1 liter, due to complex cases, we reinfuse them without washing. And this is something also very, let's say, necessary for unexperienced centers, or when you are doing very, very complex cases, then you need extra safety, and that helps.
Perfect. I agree totally. But then the problem is reporting. Because then the next question would be, if you present a study and I'm reviewing it, I want to know in how much of the patients, how much volume did you retransfuse as a cardiotomy suction in a mini system?
Yes, you're right. We always report, but don't forget, this is real practice here, and we want people to apply in our philosophy as a standard practice or 100% case mix MiECT system. So if you want to do it, I believe this is a very, very nice strategy. I appreciate how experienced you are. You have the plugin with smart connectors, but I can tell you, if you go to places that they are not using MiECT at all, trying to convince them to advance their surgery, they say, oh, this is nice, because they feel really comfortable with this.
I totally agree, and that was my starting comment.
Okay, we agreed both. Thank you.
Thank you very much. So I believe that we can move on to another.
Maybe Marco
yes.
Diasegno was back, so you finish his comment.
Yes, Marco, could you finish your comment on?
Yes, sorry, I lost my connection all of a sudden. And yes, with central cannulation, central venous cannulation, venous return in aortic palpation, minimally invasive is not a problem. It's not a concern. I don't feel any difference compared to full sternotomy. I mean, this is not the point. This is not the point. While I like to emphasize again, this is a very important point from Antonius. I think safety and technical complexity are considered the major concern with MiECT from those who want to start. So make it safe, make it simple, will help MiECT to penetrate into the routine practice. So we use type 4 modular, and we are very happy with that. Because and with that, we've been able to demonstrate superiority compared to normal CPB that wasn't optimized, but we really pay attention to blood management. And in our mini AVR patient, we could show, that was published a few years ago in the European Journal, that with MiECT, we had less hemodilution, less blood transfusion, less atrial fibrillation, and more ultra-fast track, which is the reason why we're using more and more MiECT in our mini AVR patients.
Thank you, Marco. Ashraf would like to.
So may I just ask a specific short question? What venous cannula do you use, and where do you insert it? In the groin, in the superior vena cava, or?
Right atrium, and we have double or triple staged cannulas. They're available with the Medtronic, I think, or ex-Livanova, and there are multiple cannulas that may be efficient for venous return. Right atrium, anyway.
Okay, thank you very much. So we need to proceed to the next presentation. It's Marco Stechauer presenting MiECT effect in reducing microemboli. So we'll open the issue of microembolization. Marco, thank you very much for joining us.
Thank you very much. I'm really proud that I am able to give a presentation on your meeting. Up till now, we are discussing a lot of the systems, and I will dive into much more detail in the MiECT system. I hope you can see my presentation. The organization asked me to tell something about the effect of MiECT on reducing gases microemboli, but I was so free to add some things to this title, and I think it's more a field's interesting. to tell something about the differences between the systems we use nowadays, because I have some nice data about it. This is the way I look nowadays when I leave the hospital in Nieuwegein in the Netherlands. When you talk about gases microMRI, you have to be aware where they come from. Well, they come from the intervention of the perfusionist. In the literature, people mention that low level of a reservoir, probably especially in open reservoirs, this will be the case. What a lot of people forget is that also the venous side, air is coming in through, for instance, little tear in the atrium, or when an anesthesiologist gives medication, it will go into your arterial, into your venous line. Air in the venous line will always be measurable as very small gases microMRI in the arterial line of your system. So just to give you a small example, if you have, here you see a GME activity during time. If the perfusionist is drinking coffee, nothing happens. If you give volume, you see a little bit activation. So you have to be aware of the sources. If you do something, you will see small microMRI. In this case, just before we stopped the perfusion, anesthesiology gave 10 cc of calcium, and this gave us almost 100% of the GME volume entering the patient. First, I told you I would explain something about all the systems and the GME entering the patient. First, the semi-closed system, as we use in the Netherlands a lot. So that's a collapsible reservoir, a pump, an oxygenator, and back into the patient. We measure our GME with the bubble count at 200. I just go to the results, and today we focus on what goes into the patient. So what you see here is the volume of gases microMRI entering the patient in the semi-closed system. So that's between 0.3 and 1.5 microliters. If you go to a MiECT system, which is shown here, it's a quite standard system we use with a venous bubble trap, centrifugal pump, oxygenator. And if we measure in the arterial line, we see 4.3 microliters entering the arterial line of this system. I will just, in a few slides, I will give you an overview of all these results. This was from a study we did with 71 patients. I'm glad that I was allowed to show you these results. These are results from the the Erasmus University in Rotterdam. And I have to thank Emma Bashir to show her data and her results. They compared open versus a closed system, and both from the same manufacturer. And what they showed was that the open system, a median volume of an arterial volume of 0.09 microliters entered the patient, and in the MiECT system 3.6. And if you keep in mind, 3.6 microliters is almost the same what we found in our system, which was from another manufacturer. So again, here the overview: open system 0.09, semi-open system 0.3 to 1.5 microliters, and the MiECT system more microemboli are entering the patient. Well, you can question, of course, is this so bad for the patient? So we did an experiment with the MiECT system, and we compared a lot of biomarkers for various endpoints. We did not find any association. We did find some increase of the biomarkers, but we did not find any association between GME and these biomarkers. So that was one of the conclusions of this article. No association was found between GME and the various biomarkers. Besides that, we also did an experiment with the Technical University of Twente because the bubble counts are very difficult to validate. You cannot calibrate them. You just assume that they are measuring correctly. So we did a test with an in vitro system wherein we optically viewed the microbubbles which were generated, And of course, we compare that with the bubble counter. And we noticed that the radius was measured by the bubble counter almost 2 to 3 times larger. This means that your volume is measured 25 times too large, which means the 4.3 microliter which we saw entering the patient with the MiECT system could probably be divided by 25, which means not 0.17 microliters. So this brings me already to the conclusion. Feels a bit strange to go so fast through all these studies, which took years to do. But the conclusion is that MiECT system seems to pass more gas microemboli into the patient compared to open and semi-open ECC system. However, the contribution of these microemboli may be overestimated. I showed you on purpose, of course, the example of anesthesia. I think we have to be very aware of the sources of air entering your patient, and probably we can gain much more in this field to reduce gas microemboli entering the patient. Thank you for your attention.
Marco, for your very, very interesting presentation. So are there any comments? Apostolos, do you have any comments regarding gaseous macroemboli in the venous line? So what do you see from your experience?
Many years ago, we did an extensive research on that matter with the GAMT bubble counter, comparing the two systems during CBB, and we found that MiECT system produced less microbubbles, especially in the part of the arterial line. That's my comment.
Thank you. So
Well, maybe I can say something.
Yes,
it's clear that there is what is very interesting. I think it's very difficult to judge the effects of microemboli, but in MiECT systems usually have a venous bubble trap and no cardiotomy suction. So that's why I'm a bit surprised that you were able to detect more GME in a mini system as opposed to a conventional system. But does this mean that maybe because in the mini systems usually there's no arterial line filtration involved, and then other aspects like you have maybe a more open venous blood vessels, and then maybe more injection by the anesthesiologist or more interventions as opposed to conventional circuits? Maybe you can talk a little bit about the causes why this could be happening.
I want to add in this matter that in conventional system we had an extra arterial filter, but we didn't have arterial filter in the MiECT system.
And if I can comment also, I think it makes some sense that you see a little bit more GME in a mini system because the velocity of your blood will be much higher in this system. So if you add a little bit of volume, it will run through your system. And what I try to stress is that the GME you measure are really very, 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 very small. So I won't be worried that I see a little bit more in the MiECT system, because obviously there are much more advantages of a MiECT system as we see this morning. But if you have a large reservoir, you will have some more kind of stagnant blood, and there your GME will be able to rise. And in a mini system, that's not possible. I think that's what we're looking at.
Thank you very much, Marco. And for the sake of time, we move to John Merkin, who recorded a very, very interesting update on advances in cardiac surgery monitoring. So we need to view it and then have some time for discussion.
Good morning. Today I'd like to speak to you a little bit about advances in cardiac surgery neuromonitoring, basically focusing on three questions: why do it, what type of techniques should we use, and how do we manage any changes that we see. When we speak about why should we do neuromonitoring, one consideration is research. The expense, expertise, and availability of these various technologies, however, is usually inherent in the type of studies that are being done. And certainly we've had opportunities to look at transcranial Doppler, retinal fluorescein angiography, jugular venous saturation, xenon cerebral blood flow, multi-channel EEG, functional NIRS, and all of these data derived from these various things can be analyzed offline. And the whole point of this is so that we can gain some insight into the mechanisms of injury and hopefully generate therapeutic strategies to help improve patient outcomes. From a clinical standpoint, however, expense, expertise, and availability are certainly the rate-limiting steps. But in most centers, at least, there is an availability of depth of anesthesia monitors, cerebral NIRS, or the option of not doing any particular neuromonitoring. The idea in neuromonitoring, however, is the ability to intervene, potentially guide therapy, and improve outcomes. So when we speak of depth of anesthesia monitoring, it's important to recognize that these have been associated with the early detection of acute ischemic events in the brain, and also that there's a growing recognition that some patients do seem to be exquisitely sensitive to anesthetics, require much less anesthesia, have very low BIS associated with these interventions, and consequently, I do believe it's not the anesthetics per se. I think it's rather the fact that they are demonstrating one has a particularly frail patient with presumably less bioreserve than may have been otherwise recognized. The ability of the NIRS cerebral oximetry is the ease of use. These are placed on the frontal regions, monitor a brain area of approximately 1 cubic centimeter, but are susceptible to extracerebral contamination that may provide anywhere from 7 to 13% of the signal that's being generated. However, despite these limitations, we do know that significant cerebral desaturation is associated with a variety of adverse outcomes. And we had originally published a study where we showed that patients who had significant desaturations had a significantly higher incidence of major organ morbidity and mortality, and a strong trend for greater neurologic injury in comparison with patients in whom we aggressively treated brain desaturations. This has been also demonstrated by the group from Johns Hopkins, in which they looked at 450 patients undergoing cardiac surgery and showed that, again, the extent and duration of cerebral desaturation was also in their study associated with major end organ morbidity and mortality. And they also demonstrated that this was associated with an increased risk of stroke, showing that, once again, cerebral desaturation is associated with a significant risk of adverse outcome. The important thing to recognize, however, is that this is not just a harbinger of bad news, but that very often these desaturations will respond to a physiologic intervention protocol. And we had reported that a number of years ago, creating a physiologically based intervention strategy such as you see here. And it's important to emphasize that transfusion of the patient is one of the last steps in that algorithm. We think that the majority of times there's a number of more physiologic factors that can be influenced, including unrecognized venous hypertension, as was discussed yesterday. We've certainly seen cases with cannula malposition or repositioning of the heart, elevation of the heart, producing effective occlusion of the SVC with a significant rise in cerebral venous pressures, compromising the ability to perfuse the brain. So this is just at least 3 major trials, now over 700 patients, which have all demonstrated anywhere from an 88 to 97% efficacy in restoring brain desaturations when it's treated utilizing a physiologic intervention protocol. So what's the future then? Well, we're all aware that NIRS only has limited coverage. We just look at a small region of the frontal lobes. We've certainly seen patients in our own experience who've had no significant brain desaturation, but unfortunately have had an MCA region stroke. So we've now been interested in looking at bihemispheric coverage with functional NIRS. As you see here, we have a CAP has 256 channels available, and we think this will be particularly important, not necessarily for routine coronary or valve surgery, but we do believe with hypothermic circ arrest, and particularly the use of selective cerebral perfusion, this will help us to ensure the adequacy of perfusion, since there's a number of cases now in the literature where focal areas of ischemia have been detected and have been remediated by changing the perfusion management in such cases. The other concern, of course, is the extracerebral tissue, as well as what is the optimal brain oxygen saturation values. We've certainly seen evidence growing in the literature that not only desaturation, but also hypersaturation is associated with adverse outcomes. Most recently, studies now looking at delirium, finding that this is a harbinger in a number of patients for this type of event. So we think that the use of, the use of broadband NIRS will allow us to look at oxidative metabolism, and this will let us know that the substrate is being delivered to the brain in adequate concentration to preserve normal oxidative metabolism, which is obviously the ultimate goal of all of our clinical management. When coupled with diffuse correlation spectroscopy, should allow us to look at regional cerebral blood flow so that we'll have a very good correlation between regional flow metabolism coupling. And since this is the motor of autoregulation, and we know that autoregulation is associated with adverse outcomes, this will help us to hopefully improve patient outcomes. So lastly, I'd like to remind you all about the next upcoming 4th biannual MiECT Symposium, hopefully held next year at Niagara-on-the-Lake in Canada, June 16 to 18. And Cyril Sarek will be the president of MiECT at that time. He'll be convening that meeting. And so lastly, I'd like to thank you all for your attention, and particularly Efkaristo to all of my Greek friends and colleagues. Thank you all very much.
Thank you, John. So we all thank John for his very, very nice contribution. He went deep to an issue of neuromonitoring in cardiac surgery, but he finished with the best way. So in the sake of time, it's now time to pass to the next session. And we can keep our comments for the Canada meeting. So we all give a date. Please save the date for the Canadian, for the minimally invasive, for the MiECT Symposium in Canada, where we will have the opportunity to discuss a lot about monitoring and neuromonitoring. And as pointed out yesterday, there is a great space for investigation of microcirculation in cardiac surgery, and especially in minimally invasive extracorporeal circulation, because difference in microcirculation will give a very, very great insight on the pathophysiology of minimally invasive extracorporeal circulation. And this is a field that we need to advance. So I would like to ask Professor Beaufreton to close the session.
Thank you, Polychronis. It has been a very fruitful session with a lot of discussion. And it is a fact that there is an enthusiasm about MiECT, and that we should go on and continue on this direction. And I hope that we will be able to reach physically next year Toronto and Canada for the next meeting, because it's always better to be all together in the same meeting than being on the web session. So I confess that I would really appreciate to reach the next session physically, and I hope that everybody would be able to do the same. And I can leave you the microphone, Polychronis, if you want to definitely conclude this session before going on.
Okay, thank you very much.
Right. Thank you all for your contribution for this very nice session that you offered. And we need to move on and go to the next session, which is an update in COMICS trial. And we will hear what we have yesterday discussed as board members here with the team, the new trial that we are about to announce. So before this, we will have the update on COMICS trial, which is, as you have heard many times throughout this meeting, what we all wait for, see what is the result of the biggest so far randomized trial between the conventional or the optimized versus minimal invasive extracorporeal circulation. So we have with us Gianni Angelini from Bristol, chief investigator and the coordinator for this interesting study, to give us an update on the trial. So Gianni.
I would like to do that, but I'm sharing and it doesn't let me in. Wow. Sorry. I'm trying to share the screen, but it doesn't let me see the slides. Can you see the slides?
You just need to open the PowerPoint. Is the PowerPoint?
Yeah.
Yeah.
Yes, we see now.
Okay, great. Good morning to everybody. And good to be together even from a distance. Briefly, for the people who are not familiar with COMICS, I will run a few slides just to explain what the study is about, which is conventional versus minimally invasive extracorporeal circulation. And the aim was to test the effectiveness and cost effective of the two systems. The object was to look at primary composite endpoint of 30 days, and then of course we look at secondary endpoint and cost effectiveness. Patients receiving CABG only, of AVR only, or CABG and AVR were part of the study, and a few of the usual exclusion criteria. One of the things which we emphasized was the need for expertise prior to the use of the MiECT. And in fact, the center who participate, which I'll come to that in a minute, they were all very experienced in using this technique. Now, this is the important bit. The primary endpoint was a combination of 12 post-operative serious events at 30 days. And here they are. Apart from death, MI, reintubation, tracheostomy, gut infarction, mechanical ventilation prolonged for 48 hours, AKI, stroke, reoperation, need for PCI, serious sternal wound infection, and septicemia. And as you can see, these are all pretty important clinical outcomes. Secondary endpoint were like blood transfusion, ITU, hospital stay, and so forth. And this is where we started. The sample size, which was calculated as part of the study, was 3,500 patients divided in the two groups. And this was based on an outcome of primary endpoint of around 15%, which was very much shaped from our Title II study. These were the center which entered the study, and with the exception of Plymouth, who had to withdraw, they are all still part of the study. And this is what happened. This has been the progression of recruitment over more than 2 years. And if we just concentrate on this, which is perhaps the most important part, at the moment we have randomized 1,057 patients. Unfortunately, various things, not least COVID, have impacted quite dramatically on our ability to recruit. In June, as you can see, we were running at about 45 patients a month, which wasn't perfect, but it was quite good. But then again, various resurgency of COVID have led to a pretty much reduction in the number of randomized patients. As you can see, 15 in October and November, which is almost finished. We have only randomized 7 patients. And again, I guess because of COVID, 4 centers now have stopped randomizing altogether. This is the recruitment according to the centers. And this is the event. This is a complicated slide, but all really matter is this. Our event rate is a bit less than 10%, which is not quite the 15% which we had predicted when the study protocol was actually produced. So what is the current situation? This is really the crunch of my presentation. We are most grateful to all the centers who, with very little support, have managed to enter more than 1,000 patients into the study. This is the biggest study so far ever conducted looking at MiECT technique. Unfortunately, the primary outcome is only around 10% and not the 15% which we had predicted. Now, this could be explained with other than the surgery and the anesthesia and the perfusion have got better over the years, or perhaps that we did not recruit the very, very sick patients. Where we are now is that the sample size of 3,500, which was originally envisaged, will reduce the power to 79% rather than 90%. To reach the 90%, we would need now to randomize 4,754 patients. And as you can imagine, this would take forever. So where we are now is we are in a situation where we decided, although the final decision will be from the TSC and DMSC committee to say that, but our view is that at the end of this year, we should stop recruiting because there is no way we'll ever reach 4,000 plus patients. And this is the results, particularly of the fact that in the last 6 months, which we had hoped an improvement in the number of randomization, it has not happened. In fact, the opposite is being seen. What we're doing now is trying to get all the follow-up data. We have written to all the centers because we got still a good 10% of data missed, even for things like primary endpoint. As you can appreciate, without the data, there is no trial. Without the data, there won't be any results. Without the data, there won't be any publication. This, despite of the disappointment of having to stop for not having been able to recruit the necessary number, I think is a great success. And we should congratulate all the centers who have put a lot of effort into this. The final push, please, is for you center to return us the data. It will be a very valuable information which will lead to an equally valuable publication in a top journal. And we hope to have the full set of results by the time of the Canadian meeting and a publication ready in the second part of 2022. Thank you. Thank you very much.
I don't know if Barney is online to comment on what, yes, he's here, what Gianni has already presented. So Barney?
I don't think I have a lot to add to that, except to say that the size of the trial with the patients we've recruited so far will allow us to, it will say, we can still confidently say the treatment effect is not as large as so and so and so and so. So we have the previous systematic reviews that have reported a variety of treatment effects, but typically very large treatment effects. And we can either say they're plausible or we can rule them out.
Okay, so I don't know if my co-moderators have anything to comment on this occasion regarding COMICS trial. First, Vice President of MiECT, Serdar.
Yes, thank you very much. So in our clinic, as you know, we just changed the hospital and moved to another one. So we have some difficulty in between, but we later solved the problem and tried to recruit as much as possible. But of course, the COVID era really had a great negative impact on the collection of data. And I believe we can have some outcomes until we finish collection of data until the end of this year. So, so we try to catch up for our previous pace and in the second half. And so we are finishing loading all types of data in a few days, I believe. Thank you.
Okay, Ashraf?
Yes, just to summarize, I think this is the common feeling of everybody. Everybody's disappointed that we are discontinuing the study, but it's very realistic. It is mainly attributed to the COVID situation, but also on the event rates that were quite lower than anticipated. And we're hoping to see the results. At the end of all, it was very hard work for all centers, especially with most of the centers having no financial support for such a study. And I think this is something unique to the study that has to be pointed out. This is more an initiative from believers in the technology in order to push the technology forward and get scientific evidence for that. Solid scientific evidence, and we hope for the best when analyzing and looking at the results. And the main thing and the most important thing at the moment is to give maximum effort into getting these data to Bristol so that they can do their analysis of the study. And this is something that we have to concentrate on the next 2 months till the end of the year. In spite of maybe a disappointment that would be, yes, keeping us from doing the hard work.
Right, so it seems from all views that there are 3 major parameters. I will include another one that made the situation to reach up to this point. One is that we had a group of experts, very highly selected centers that are having very low event rate to be reported, maybe even that we are utilizing a lot of cabbage cases and not combined, that would give us extra MACE. The second thing is that these centers are really comparing MiECT with OPEC and not with conventional systems. So they are really utilizing very, very advanced conventional systems that are not the usual, it's not real in most of other centers, just because all of them are believers of optimizing sets. And that's why we have actually an OPEC versus MiECT trial, which is even better for the results, as Siri pointed out earlier on in the previous session. And the third and a major struck for us was the COVID situation, which really made us to struggle having cases to be recruited, and also even finding space into operating theaters and ICU to host our patients. Sometimes we even had to transfer patients that had COVID after surgery, and that was really, really trouble how we manage these patients that are not anymore our patients postoperatively. Anyway, the major issue also was the lack of financial support, and altogether we've reached a decision with Bristol, with our senior trialist, Professor Reeves, and the chief investigator, Professor Angelini, that as society we're happy to stop the trial end of this calendar year and have the results of the biggest trial ever comparing MiECT with conventional or optimized CPB. So this is the situation so far. I don't know if you have anything to comment, Gianni or Barney, on this?
No, I mean, all I would say is thank you very much to all the center who have put a lot of effort despite of all the circumstances. And I'm sure that we'll be able to come up with a very good report and a very good paper, which will be of some importance.
Yes, I'd go along with that. And everybody must realize that the COVID situation is going to affect a lot of trials. And I'm sure that this one will be seen in that light. I mean, you can't do a trial if you can't recruit the patients and operate on the patients.
Well, on behalf of MiECT, I need to express my sincere thanks to both of you and to all your efforts, all your infrastructure that you have offered, all your expertise and the robust way of producing so far all the evidence through these reports and leading us through this trial. I hope, as Gianni pointed out, that we will be able to have the outcome soon, probably published next year, second half, and then we will see how it goes. So I thank both of you. And we said as society that since there are unanswered questions to our let's say society's goals, we needed to keep researching, keep trying to answer these questions, and for this we will go on with a multi-center trial. And what we have designed is that we will try to take advantage of all the experience we gained from COMICS trial. And we are announcing today that we will start early next year, before even the results from COMICS trial being analyzed, so as we don't have any bias from the results. So we are ready to start a new trial that will be presented from our moderator, for our coordinator, who would be polychronis angionesis, and our senior trialist, who will be Professor Papazisis from our CRU in Aristotle University. So polychronis, will you announce the trial that we are about to start?
Yes, thank you very much. So we will, so in this environment, in this COMICS environment, and this stressful situation for the global community, but considering the dedication of this expert group on MiECT in minimally invasive extracorporeal circulation, a new trial was born. It's called MiECT. We will see it in a presentation now. It's the other presentation. Modular MiECT is here to take part in the MiECT study. So, and Gianni Angelini said that actually the recruitment rate reached the best that we could, and by providing 1,057 patients. But there is still need for a study comparing conventional to minimally invasive extracorporeal circulation. And this was particularly stressed during the presentations that were done yesterday and today. despite the evidence that is provided by major scientific societies, that as we've seen, it's a class of recommendation 2A, level of evidence B, in terms of biocompatibility, in terms of reducing the need for blood transfusion, in terms of improving clinical outcomes. Rob Baker clearly said that this evidence is not enough and we still need robust evidence to provide, to give an answer to whether minimally invasive extracorporeal circulation is superior to conventional extracorporeal circulation. So in this environment, a randomized controlled trial called MiECT is born following the COMICS trial, following the efforts of Gianni Angelini and Barney Reeves and the Bristol Clinical Trials Evaluation Unit that really contributed to gain significant insight on how to do a proper trial comparing minimally invasive versus conventional extracorporeal circulation. So in this field, regarding the primary outcome, the incidence of primary outcome, as we've clearly seen in this Congress, it will be very, very low in terms of hard endpoints. Circuits are optimized, including coated tubing, short tubing, centrifugal pump, sophisticated techniques like the retrograde autologous priming, like prime displacement. Centers use goal-directed perfusion. The industry, all companies showed that they have sophisticated software for providing goal-directed perfusion, which improves clinical outcomes. And also, there is definitely a low percentage of high-risk procedures. I mean, we were not calculating that we will include 85% coronary cases. And it's a selection process, yes, definitely, even from the surgeons, even from the perfusionists, even from the whole teams. So there is a kind of selecting easier or selecting certain cases for getting into the trial and avoiding a little bit cumbersome and difficult cases. So this created the low percentage as compared to other studies. So if we want to reply to the question, conventional CPB is not as safe and effective as minimally invasive. Yes, this could be the case for the first machine. But in the real world, conventional cardiopulmonary bypass is absolutely safe and effective in all types of cardiac surgery, and there's no question about that. So we don't have to spend our efforts in trying to provide an answer to that. We have the evidence-based guidelines. They are all green, 2A, level of evidence B, but Rob Baker insisted that he needs more guidelines to more robust evidence, more evidence to penetrate minimally invasive extracorporeal circulation and convince perfusionists to convert one technique towards the other. So the real question is that in the real world, is MiECT a better perfusion technique or the best perfusion technique compared to the conventional technique in reducing the incidence of complications that could be related to perfusion? So we will try to give an answer to this question by testing the hypothesis that MiECT is effective and also to estimate the difference in the percentage of participants having a composite primary outcome, as we were doing in the COMICS trial, and to estimate differences in secondary outcomes as well. So the primary outcome will be an endpoint that will consist of major perfusion-related clinical outcomes. That is, of course, death, type 5 MI as defined in the fourth universal definition of myocardial infarction, stroke, acute kidney injury as defined with the Akin criteria used in other perfusion-related studies, mechanical ventilations for more than 48 hours, re-intubation, any kind of reoperation, including percutaneous coronary intervention, and septicemia confirmed by microbiology, while secondary outcomes will include blood products use, postoperative incidence of nuance and postoperative atrial fibrillation, ICU and hospital stay, other serious adverse events, and also health-related quality of life that could give us an answer to the question that provides, let's say, the best indicator of an improved outcome in cardiac surgery nowadays. We based the design of this trial in COMICS, and this was based, as Gianni said, in Tier 2 trial, which included a 40% CABG. And we've seen that the rate of complications is relatively low in terms of stroke. Myocardial infarction is 1.5%, 0.3%. Gut infarction is near to zero, where we have acute kidney injury or as a serious complication. And this was actually seen in other studies as well. And we also used studies that use goal-directed perfusion, because this is a very, very important parameter taken into account when designing a study on perfusion. So we can see that with using goal-directed perfusion, we have an incidence of acute kidney injury of 15%. Without using it, you have a 24%. So there is an incidence of 20% of acute kidney injury. And actually, what we will do in MiECT study is that we will define from the beginning that 50% of cases will be coronary cases, about 30 to 35% will be aortic valve replacement, and the 15 to 20% will be mixed cases in order to have the primary outcome. Otherwise, the study will have a lower primary outcome as well. And considering a power of 80%, as is used in many studies, and considering that the outcome frequency will definitely be around 20%. If it's lower than 20%, then this means that we may are doing a selection of the best surgeons who operate on the best patients, because otherwise in the real world, there should be a minimum outcome frequency of 20%. Then, providing that we will we need to find a risk ratio of 0.7, so that we will seek for a 30% reduction in the risk of complications. So from 20%, the rate will get down to 14%. Then this means that we will need to recruit 1,200 patients in order to have the adequate power to give results. Eligibility criteria will be the same as in a COMICS trial, and this is because they were very, very well designed by Gianni and Barney. The main issue will be the main issue will be emergency surgery for excluding a patient, salvage surgery, major aortic surgery, or having an acquired or congenital disease that produces anemia, or inability to give informed consent, of course. So the trial scheme will be to randomize in each arm 612 patients and keep the 30-day follow-up for the primary outcome and the 90-day follow-up for the quality of life evaluation. Because as we all know, for the first month, it's very, very difficult to detect the quality of life improvement with after heart surgery. The study centers, these centers are dedicated in minimal invasive corporal circulation. The blue ones are centers that have declared that they will follow the study. So it's Thessaloniki, Ankara, Bern, Hull, Papworth, Braunschweig, Ulm, Bari, Dammam in Saudi Arabia, Toronto, Hammersmith, and Göttingen in Germany, while we have contacted other centers, Coswig in Germany, Kiel in Germany, Regensburg in Germany, and Ancona in Italy, who actually expressed their interest, and they will seek whether they could contribute patients to this study. Is it feasible for the outcome frequency of 20% and recruiting 1,224 patients by recruiting 50 patients per month, which was actually the aim in COMICS trial? We would need approximately 2 years. By recruiting 40 patients per month, that we did some months in COMICS trial, we will need about 2.5 years. It's feasible, but also if we include 30 patients per month, that has been actually achieved in COMICS trial in many months, we will approximately need 3 years and 4 months. And this is feasible as well, as long as we are dedicated in this technology. And the design of the trial, the coordinating center, will be the clinical research unit at the special unit for biomedical research and education in Aristotle University of Thessaloniki. And the lead trialist will be Professor George Papazissis. The chief investigator in this center is Professor Kyriakos Anastasiadis, and the study coordinator will be myself, while the clinical research unit is part of the Aristotle University of Thessaloniki and the special unit for biomedical research and education. And it's a highly developing research institute in Greece, and it will be an honor for them, I believe, to take this trial. The chief investigator, Professor Kyriakos Anastasiadis, is the head of the School of Medicine in the same institution, while I will be the study coordinator, which will have the responsibility of coordinating all centers, because I all know you. And then we have the major principal investigators that have designed and approved the protocol of the study. It's Andreas Liebold, lead for EU countries from Ulm in Germany, and Prakash Punjabi in Hammersmith, lead for non-EU countries. Then is Professor Serdar Yunagudin as a principal investigator, who is contributing a lot of cases in the COMICS trial, and Ashraf El Azawi in Göttingen, and also Cyril Serik in Toronto General. The registry, the randomization procedure, and the database will be held by Dendrite Clinical System, which is a lead in cardiac and thoracic databases. They keep the European MiECT Adult Cardiac Surgical Database, the UK Heart Valve Registry. They produce the results from the Society of Cardiothoracic Surgeons of Great Britain and Ireland. And I believe that the Dendrite Clinical System is an asset in clinical registries, and they will randomize, they will create the database for randomizing patients and keeping the data and giving us descriptive statistics of the data. The resources required from MiECT will be a data manager, let's say, from our point, from the point of the coordinating center that will monitor the data entered and that will contact the centers. As Gianni and Barney said, that the rate of responding sometimes is low. So centers need to be contacted in order to give the results, because without the results, there is no trial. Now I would like the previous slide. Could you please go 2 slides? The previous one? Thank you very much. We've designed a very, very important trial steering committee and data monitoring and safety committee. So the chair of the trial steering committee and the chair of the study is the former president of the society, Professor John Merkin, together with Thierry Carrel. They will be the major key players in the trial steering committee, as long as with Professor Vasilikos, who is a professor of cardiology in Aristotle University Thessaloniki School of Medicine, Mark Bennett, who is a consultant anesthesiology in Swansea, and Professor Georgios Karapanagiotis, who is an assistant professor of cardiothoracic surgery in our department. The trial steering committee would lead with trial representatives. I've told you the major, who are Kyriakos Anastasiadis, Andreas Liebold, Prakas Punjabi, and me as a study coordinator, and together with the coordinating center and Professor Papazidis will lead the trial. Then we have the data monitoring steering committee, and the chair is the Professor Panagiotis Bamidis, who is a professor of medical physics, informatics, and medical education. He's a very, very experienced professor in data analysis and data monitoring. So he will chair this committee together with Professor Asterios Karagiannis, who is the former head of the department of the School of Medicine in Aristotle University of Thessaloniki, and a very, very experienced researcher. Professor Thodoros Karamitsos, an experienced researcher and associate professor of cardiology, and the statistician of the study will be the associate professor of medical statistics, Anna Bettina Heidic. Key members of the trial team will conduct the data monitoring and safety committee. Actually, there are no safety issues in this trial, so it's mainly a data monitoring committee to report on the progress of the trial. As we've seen, it has been very, very important, this committee, in COMICS trial. So I want the previous slide, please. So I will finish with the centers again. So please keep this slide on. So these are the standard standards that have been conducted and have promised that they will embark on this trial. And then I leave the floor to the presidents.
Thank you, Polychronis. Before I go on with discussion with my co-chairman, I will ask Professor Papazidis, our trialist, to comment on what we have heard so far. So, Professor Papazidis.
Good morning. Good morning, Professor Anastasiadis. Good morning, everybody. Apologies for any inconvenience because I'm in Italy with a very bad connection. So I had some slides to present, but unfortunately I can't do that now with a 4G connection. However, it's a pleasure. It's an honor for me and for the clinical research unit of the School of Medicine of the Aristotle University to participate in this trial. So we will try to do our best. Few words about our unit. The clinical research unit is designed and dedicated for research. It has 18 beds for that purpose, and our main goal is to perform bioequivalent studies, meaning studies, pharmacokinetic studies, in order to present bioequivalence of generic drugs compared to originators, and also to perform phase 1 studies. We have already participated in vaccine trials with new mRNA vaccines studies. So we participated in phase 3 studies, having already published some results. And we also are involved in pharmacoepidemiology and pharmacovigilance studies. We have a strong collaboration with the Uppsala Monitoring Center, which is the WHO collaborating center for international drug monitoring. So regarding the MiECT study, which is, as Kronis already presented, a multi-center, two-group parallel randomized controls trial using CE mark devices within the intended purpose, so that it's a trial not classed as an investigational medicinal product or a device trial. So we don't have really any issues with our national regulatory committee, a national regulatory organization, and we have already contacted our national ethics committee and have the approval for the study. And also we have the approval of our IRB, of the Ethics Committee of the Aristotle University. So the next steps is to finalize the protocol and to prepare, of course, all the related documents, meaning the participant information sheet, the informed consent form, and of course the study case report forms, the CRFs, and the electronic CRFs together with Polychronis. And I hope that we will ready with these forms within the next months, and so to be ready to give the opportunity to all the other centers to make their submissions to the ethics committees. So if you have any question, I'm available, and thank you again for giving us this opportunity.
Thank you, Professor Papazisis. What I would tell everybody is the timetable from now on. We have designed the trial, reviewed the protocol with the PIs. We have submitted the protocol to our authorities and also IRBs. We'll be ready for distributing the IRB forms and the CRFs to the centers in the next month. And we are in parallel designing the registry from eDendrite, and we will be able to kick off the trial early March, I think. This is the concept. So far, 12 centers have confirmed, and we are discussing with 4 other centers. Actually, a couple of them already confirmed, as Regensburg and probably Kosvik. So we aim for 16 centers to participate, and that would facilitate a lot the recruitment rate. And from now on, I think what has been left is to prepare actually very carefully the first steps. And as we discussed yesterday in this board meeting that we had all together with the major stakeholders here, what we would need is to do a cumulative effort and have a kickoff all together, so as we have a robust trial. So now I will pass the microphone to my co-moderators, Serdar and Ashraf, to moderate. There are a lot of people being connected online that might have comments, questions for everyone here. Professor Papazisis, Professor Andonisis, and all of us who have designed this trial, and we are very keen on answer any questions to everybody who will participate for this session. So, Serdar and Ashraf. Can we see all the online people together so as we know who is participating?
Yeah, so, okay.
All of them are online.
Yeah, so we don't see them. Okay. So we we are very much excited to start to this new level and a new study. And I believe with the experience of the COMICS trial before, we'll be very much motivated and I believe much more successful to collection of data and the number of centers. And hopefully we will get a very clear study at the end of this trial. So any comments or feedback from the participants?
Can I make a comment?
Sure.
Morning, everybody. Thanks for inviting me. I do represent a little bit the Italian perspective of this trial because, I mean, we recruited around 100 patients, most likely CE-ABG. Now, I think we may, I'm doing a little bit the devil advocator. Obviously, I'm very, very happy, super happy to participate to this trial, and I will keep on contributing as much as we can and trying to, you know, convince a colleague from Italy to jump in. Now, in terms of the level of risk, I think we should aim to you know, to recruit, you know, patient at higher risk for surgery. Now, in terms of isolated aortic valve, the number of this kind of procedure in Italy has literally, you know, dropped down because of TAVI. What actually has left to us in terms of like conventional surgery is AVR in younger individuals that clearly are not, you know, they have like an acceptable Euroscore or STS, so they're not that much prone to develop complication. So this is the first consideration. The second one is we normally use minimal access, like right thoracotomy or mini sternotomy, like a really small access, which, at least in my hands, may, you know, render all the setup a touch more complicated in terms of venting the left ventricle. You know, in such a small access, you know, I should aim to vent the left ventricle, you know, in a very good way. So this is the first comment. The second comment is about the rate of the event. I have in front of me, for example, the FAME-3 trial, which is the latest trial published in New England that compare PCI and CABG. And this is actually a cornerstone because it says that CABG does better than at 1 year. PCI, you know, has more favorable outcomes in terms of early outcomes, bleeding, renal failure, and probably this is where we should actually focus a little bit to try to even more optimize the early outcome in order to be more, how do you say, even more, I would say less inferior to PCI in terms to this early outcome. Yet, for example, the incidence of a kidney failure, it's 0.9%. So it's very, very low. What strikes me is the rehospitalization at 30 days, which is 10%. I'm not sure why it's so high. Probably it's due to a wound infection, or that again can be linked to bleeding, or. So the question is, in order to increase the frequency of events, I'm not sure if the rehospitalization is included. Is it included?
The rehospitalization is included as long as it is related to a primary outcome event. So we will not include any rehospitalization, because let's say we had a patient that broke his leg.
Or COVID.
Afterwards,
Or
okay.
COVID.
Or COVID.
Okay.
So it should be related, the hospitalization, to one of the primary events. Otherwise, it's not fair to include every rehospitalization. In Greece, we do not have rehabilitation, let's say, facilities, and patients easily come to the hospital even for a minor issue. This is it. And also for your first comment, minimally invasive cardiac surgery is not included in the trial. So there needs to be the full sternotomy approach, because this creates another environment. This is another procedure.
Yeah. Yeah, the reality, at least the vast majority of us in Italy, even for like, I wouldn't say marketing, but to be, competitive, we try not to do. I mean, in my unit, I haven't performed a single, ABI in sternotomy for some time, to be honest. And sometimes even combined procedure, we tend, if the patient is not that young, to do like a hybrid approach, like ABI and then PCI, or try to.
Marco, that was our discussion from the first beginning to COMICS trial. If you start expanding this to other techniques, then you don't know the result, if it is coming from your technique or from MiECT or from whatever. Then you can claim that this is better because you had, mix. So we exclude all that. Unfortunately, if you don't do full sternotomy to AVRs, we will not participate to that stratum, go for CABG. But as we said, we will keep it for full sternotomy, all procedures, so as we will just dedicate our result to perfusion. Otherwise, we will dilute.
I understand that would obviously impact the recruitment rate.
I know, but this is prerequisites. Otherwise, as I say, we will have a lot of bias, which is the result coming from.
Thank you.
Okay, so
I just think that the crucial point that we have to point out is getting as many centers as possible on board, because we don't know what kind of COVID situation we will be having within these 3 years maybe. So the number of centers is crucial, that even if centers recruit only 2 patients per month, we still come up with 30 patients as a whole, or maybe even more. And this is the most crucial issue in my point of view.
The good thing is, last week, Christoph Schmidt from Regensburg said he would participate with his team. That's for the first time. He didn't participate in COMICS, and also Adrian Bauer said they will in a couple of months. So these are 2 more centers, 14 centers in total.
But that was one of the problems, in my point of view, in the COMICS trial. We have to have these centers on board very early. One of the problems in COMICS trial was there were 2 or 3 centers recruiting patients, while other centers didn't go through ethical committee, and this was quite devastating at the beginning, because the recruitment was much lower than anticipated. Now we have to do our homework prior to starting this study, so that from the beginning, as many centers as possible are on board. And we need more than just verbal commitment.
Okay, so Mr. Lieni from Switzerland, I think you would like to comment something. You're mute, so can you unmute yourself?
You're still muted.
Now it's okay. Now you can hear me now. Sorry,
Yeah.
Just a comment from the perfusion side. Even it has to be clean about the different systems. Type 1 until 4. I saw so much different system on the market. Even if they call that type 3, type 4, it's quite a various big variation between the clinics. Could it be possible that we as teams that we met before, and we show a bit which kind of system we will use, and you try to adapt them quite roughly, but so we have not a big variation between the sets to make it comparable.
We said we will record the system, but we cannot force the centers to change their setup. So what we said is type 2 to type 4, but as Ashraf said, when you use type 4, you need to declare and report if you are opening the system, if you're infusing. But definitely we'll record everything and we will reevaluate the systems at the end, not at the beginning. It will be recorded though.
So Prakash, any feedback on this topic?
Hi, so sorry. My timing for ward round and coming back here didn't work out that well. But I would just give you my personal experience. I think the comment is quite a valid comment, and but on the other hand, units must be allowed to adapt whatever form they are comfortable with in using. A lot of the times, there is an imbalance between the adaptability for surgeon and the chief perfusionist. So what has happened in our department is we sat down and my chief perfusionist said, this is what I think will be safe for you to do because of your complexity of the variety of cases. And I personally think, it's a borderline 3 is what we use. And I think we just have to allow. The key question is adaptability. The key question is usability, and and as Kyriakos said, we are going to record everything. I think, which is good, and we may have sub-analysis, but I think overall, even if we just say overall, this was the analysis from the MiECT minimal point of view. Then we just need to get the benefit out. And my worry is, if we become too strict at this point, or we insist on some form of definable minimal circuit, then not only will the usage or the uptake or the recruitment might suffer, but I think in the long term, we have to decide whether we want to do a small focus study of only type 4 or a larger study of 2, 3, 4 and get the best out of it and have more units and numbers. And my personal feeling is, in our unit, we have had a very good discussion. Both are keen from the surgical community, and I've had personal discussions with my colleagues and they are on board. And the chief perfusionist has trained all his colleagues. So the two departments have merged. Only thing is, we have had to come to an agreement as to what is best usable amongst the majority of surgeons. I may be willing for a type 4 and do the operation, but I just want to make sure that all my colleagues are on board. So that's just my apologies once again for the delay.
Thank you. So, Ingo, would you like to comment on this?
Yep, for sure. As I said yesterday, the main issue with the study from my side is that we need manpower, and therefore we need clear CRFs. You can't spend 45 minutes to fill in this CRFs, then nobody would recruit 30 to 50 patients per month. If it's done in 15 minutes, I think it's possible to recruit these patients, even in our hospital. But if you can produce clear CRFs, it would be great and make it easy to fill in it.
Thank you. So we only have a few minutes. Cyril, you want to say something before we close this session?
Not really. I mean, I think it's a great initiative. I think we really need to continue on with this. I think we may want, since we're talking about safety, we may want to record some safety parameters, include them on the CRFs as well. But now we're increasing the CRFs, so I don't know what to think about venous air, just for unconventional and on regular systems. and the MiECT system, how long, etc. So I don't know if anybody wants to comment on that.
Okay, thank you. So Prakash, I think you want to say something.
Yeah, may I just add, I think the previous comment about the CRF is a very valid comment. And again, I just wanted to share so what we are, I don't know about everybody else, but certainly we have something which is called the NIHR, which is the National Institute of Health and Research. And within that, we have a clinical research trials network, a CRTN, which has a full group of cardiovascular research nurses. But if you get this study adopted into the NIHR as a portfolio study, then essentially you have the clinical trials network, the nursing staff, the clinical research nurses, literally on board for everything. So they go and they're very keen to identify patients, because the more number of patients get recruited, we don't get anything. Nobody in the department gets anything. But they, as a clinical trials network, specifically the cardiovascular, we have CARES, the Cardiac Surgical and Cardiology Research Network. They get credit, which is credit in form of recognition and monetary, so they can employ the nurses. So that's where the funding comes from. So we have used that. It takes a little bit of paperwork to get that done, but once you get that done, then the CRF from a surgical and perfusion point of view is very short. But most of the other things, demographics and follow-up, are done by the clinical trial nurses. So that's again sharing my own experience of how we went through everything. And that's a standard process now for us. Thanks.
Thank you. And Ashraf, you want to close? We have only 2 minutes.
I'll be very short. I have no other comment.
All right. On these grounds, I want to thank everyone, first of all, for their commitment, the hard work they have done for COMICS trial. Unfortunately, for the reasons that we have heard, we have to stop this trial. And before evaluating and presenting results from COMICS, we have carefully evaluating how we would go forward. And the last 6 months, we are designing with our society the next step, which is MiECT trial. And so, as we have promised yesterday, next month, the IRBs and the CRFs will be distributed so as IRBs to be approved and CRFs to be corrected and prepare the registry. And the aim is to kick off the trial very early March next year. So this is the news, and I hope Prakash will be kind enough to present the protocol, to publish the protocol in Perfusion Journal as soon as we will start, and see how it goes. So thank you, everyone, and we need to close. Yes, Prakash.
Just quickly, Kriya, one of the, I presume you've already thought of it, and I'm terribly sorry if I'm suggesting again, it's just registering it on the Clinical Research Trials Network, which is become very
absolutely
good and very supportive thing when you go for publication. It's really best.
Yeah, it is in the process to be done, Prakash, anyway. So thank you, and let's close this 2 days meeting because it was a lot that we've done throughout these 2 days, and I would try to make a small overview of what we have done. So what I would say is throughout these 2 days, we had an update on research, as you have seen from yesterday, all the recent advancements and all the published results that we found more interesting were presented. Also, another key point that I found out from yesterday is that the last 5-6 years that the industry is joining our sessions made a real interaction and a real connection between physicians and managers, and we reached up to the point that this synergy presented results, and a couple of products have been designed due to our initiatives, and also we have counted a lot on their efforts for medical education and for supporting us through various means, and this is really significant for this technology. Also, what we have accomplished is we finalized the focused update on our position paper, and we will be able to publish the new manuscript early next year in the Perfusion Journal, and this is something also very significant for people who are following this technology. Last but not least is the overview in clinical practice from the key opinion leaders, as today have seen, and we had a lot of extensive discussions on various aspects on MiECT, training, program schemes, and a lot of clinical issues that have been discussed. And what we've seen is that this is an ongoing process, and it's valuable input from everyone, especially from this group of experts that MiECT has. Now, last is that, as you all have appreciated, unfortunately, comics area is about to stop, but hopefully and very optimistically, we open a new and more realistic era of MiECT, which is coming, and from next year onwards, we will discuss about the results of comics and the ongoing MiECT trial, which is now our flagship and our main goal of this society. So we will have in our webpage the same format with newsletters that you get, the centers that are flagged as you see in the map, and also we will also use multimedia to try and give results open to the industry and all the people that are following comics. So with this, I want to emphasize that more than 350 people were connected every day, yesterday and today, and more than 6,000 views of this event this 1 day and a half. I want to thank Inventix once more with Live Media and Stathis, who won, as you know, the national award with our second MiECT meeting, and they really helped a lot also throughout this meeting. Our gold sponsor, which is Medtronic, which is always supporting, and especially the Greek chapter, also Behring and Eurosets that have also sponsored us. And we shouldn't forget how much now our School of Medicine and Aristotle University with the CME CPD support and CRU will be involved in iSociety, and I'm really, really happy for this. And I want to thank all the professors for their hard work so far. So can we see how we spent the last 2 days?
I thank you all for participating. Thank you for your valuable input, and I hope we'll meet soon in Canada.
So I think Canada meeting is coming, and I pass the mic to our president, Cyril Serik, to close this meeting and announce the next symposium in person in Canada. Cyril.
Thank you very much, Kyriakis. I think it's been a great update meeting as usual, and certainly hope to see everybody next year in person. I think it's an honor and privilege to serve as the president of the Minimally Invasive Extracorporeal Technologies International Society. Our society is dedicated to investigation, support, and future development of physiologically based minimally invasive extracorporeal perfusion and related therapies. It's the only society that is truly multidisciplinary. Its membership is similar to cardiac teams, approximately 30% cardiac surgeons, 30% anesthetists, and 30% perfusionists. Equal representation on the steering committee, with myself being the first president of the society. For us to truly improve patient outcomes for cardiac surgery, all three disciplines need to work together in unison. What one does during an operation has a direct effect on the other. You can't have minimally invasive cardiac surgery without a minimally invasive perfusion and anesthesia strategy. Therefore, as a society, MiECT is committed to the promotion of safe and effective and innovative minimally invasive extracorporeal technologies and techniques for cardiac surgery with scientific evidence-based rationale. I invite everyone to become a member and to promote your colleagues to become members so we can become one voice that strives for the continual improvement of patient outcomes. I think, like I said, this has been a very informative meeting with a great discussion, and I'd like to thank everyone for their participation. And I certainly look forward to meeting everyone in person next year in Toronto, actually just outside of Toronto in Niagara-on-the-Lake, from June 16th to the 19th, 2022. Thank you very much, everyone.
I would like to ask you all for your help and assistance.
All right, Mr. President, the mic to you. Yes, we hear you.
Oh, you didn't hear what I said?
Yes, can you repeat, please?
Oh, okay. I just want to thank everybody for coming. I think you know what, it's been it's an honor to be the president of MiECT. We're truly the only society that truly represents the cardiac team. I mean, 30% cardiac surgeons, 30% anesthetists, and about 30% of us are perfusionists. And we have to work together as a team. So I do believe we're to advance cardiac surgery. MiECT will certainly help do that. It's been a great discussion, great meeting, and I look forward to seeing everybody in Niagara-on-the-Lake, just outside of Toronto, in 2022, June 16th to the 19th. And with that, adieu, everybody.
Thank you all, and stay safe. See you soon. Bye-bye.
Bye.